Hello guys, you're welcome to Aloysius MedHub. Today we'll be discussing non-steroidal anti-inflammatory drugs. NSAIDs. NSAIDs, non-steroidal anti-inflammatory drugs. So NSAIDs, they have um, common properties, and these properties include they have anti-inflammatory property, they have analgesic property, and they have antipyretic properties. Anti-inflammatory property means that they reduce the rate of inflammation or arrest inflammatory processes, while analgesic property means they reduce pain, they can reduce pain or arrest pain. And lastly, antipyretic means they can bring down fever or arrest fever. So just to give you a background of inflammation. Inflammation is a physiological response to um, tissue injury and infection. Wow. So now the inflammatory process has cardinal features. So and these cardinal features include pain, which is dolor; heat, which is calor; redness, which is rubor; um, swelling, tumor, and loss of function. Now, NSAIDs, non-steroidal anti-inflammatory drugs, it therefore means that they are steroidal anti-inflammatory medications or drugs, right? Since this is non-steroidal, so it therefore means that they are steroidal. So an example of steroidal anti-inflammatory is glucocorticoids, which also have anti-inflammatory properties, just like I said. So inflammatory response may be acute or chronic. In the acute state or acute form, it is usually rapid in onset and of short duration. It provides protection following tissue injury and infection. On the other hand, for chronic state, it results from continuous exposure to the offending agent or element. Now, inappropriate or exaggerated inflammatory response leads to deleterious effects. Now, treatment with inflammation involves two primary goals. So, in treating inflammatory conditions, there are two primary things that should be on your mind. Number one is to relieve the pain of the patient. Number two is to slow down or arrest tissue damage because inflammatory process causes this. Right? So, the two things that should be on your mind in treating a patient with inflammatory conditions is number one, to reduce pain because there will be pain, and number two, to reduce or arrest tissue damage. Now, inflammation is mediated in parts by prostaglandin, which is produced by the cyclooxygenase pathway. Now, prostaglandin, prostacyclin, and thromboxane A2 are collectively called prostanoids. Right? They are synthesized from arachidonic acid derived from phospholipids. The reaction is catalyzed by prostaglandin endoperoxidase (GH) synthase. This enzyme is also known as cyclooxygenase. Now, there are two isoforms of COX, which is cyclooxygenase. We have COX-1 and COX-2. Now, COX-1 is expressed continuously in most cells, right? It means most cells produce COX-1. They are dominant source of prostanoids. I remember we said prostanoid include prostaglandin, prostacyclin, and thromboxane A2. So they are the dominant source of prostanoids for housekeeping function. Right, so that's COX-1 is the dominant source of prostanoids for housekeeping function. I'll just give you this. This is important for you to understand an example of housekeeping function. It produces prostaglandin that helps to maintain mucosal lining and protect against stomach acid. So the cells that makes up um, the stomach, right, produce prostaglandin. So this enzyme produces prostaglandin, right, and prostaglandin helps to maintain mucosal lining, right? So it prevents the direct contact between the gastric acid with the epithelial lining of the stomach to prevent its damage. Now, for COX-2, it's the principal source of prostanoids formation in inflammation and in cancer. On the other hand, COX-3 has been described recently as a splice variant product of COX-1 gene, right? So now this is the pathway for the this is cyclooxygenase pathway. Now, so phospholipids from phospholipid bilayer from the cells or the cell membrane. When acted upon by phospholipase A2 produce arachidonic acid. When acted upon by the cyclooxygenase produce endoperoxidase. When endoperoxidase is acted upon by prostaglandin isomerase produce prostaglandin. On the other hand, if endoperoxidase is acted upon by thromboxane synthase produces thromboxane A2. If acted upon by prostacyclin synthase produces prostacyclin. Right? And these are the effects of these prostanoids. Right? So yeah, these are the effects of prostanoids. Now there's an important pathway here um that is important. I talk about is the leukotriene pathway. Now the leukotriene pathway, the reason why it's important is it's important in asthma, right? Now leukotriene is one of the products that is formed, or leukotriene is the product that is formed from this leukotriene pathway. Um, it mediates smooth muscle contraction in the respiratory tract. It mediates mucus production. It mediates uh, bronchoconstriction, right? So all these things are not good for an asthmatic patient, right? So now leukotriene is formed when lipooxygenase acts on arachidonic acid, which ultimately produce um, hydroperoxy and hydroxy fatty acid, ultimately producing leukotriene. Now, um, however, there are drugs that inhibit this process, right? So the drugs that blocks the leukotriene pathway, the leukotriene receptor. So example, leukotriene receptor antagonists, which include the zafelucast and montelukast. Right. On the other hand, we have anti-inflammatory therapy, which includes the zolitons, zolitons. Zoliton inhibits 5-lipoxygenase producing leukotriene production. Now, this 5-lipoxygenase is the enzyme that acts here, right? So the anti-inflammatory therapy, the zolitons, blocks, inhibits this enzyme, right? So ultimately, leukotriene will not be formed. As a result, um, those inflammatory response such as bronchoconstriction, mucus production, which will clog the air pathway, preventing patients with asthma to breathe, right? So it will prevent all those signs and symptoms. So, so now for NSAIDs, the job of NSAIDs, right, is to inhibit the cyclooxygenase. Remember, we said the cyclooxygenase has two isoforms. We have COX-1 and COX-2. So the job of NSAID is to inhibit this. Now, all these things they mediate pain, right? They mediate inflammatory process, they mediate pain, they mediate fever, right? Pyrexis or pyrexia, or something like that. So, so NSAIDs, the job of NSAID is to inhibit this enzyme. And once it inhibits this enzyme, all these products will not be formed. And if these products are not formed, inflammation will not go on, or inflammation will be reduced or arrested. Fever will be reduced, pyrexia will be reduced, so it's antipyretic. Then analgesia to reduce pain. We get it. So right, so we'll move on. So prostaglandin I2, it inhibits platelet aggregation, vasodilation. It inhibits platelet aggregation, vasodilation, vascular permeability. Right. Now all these things, these are these are processes that takes place in inflammation. Right. So vasodilation, the blood vessels dilate, vascular permeability. There are channels between the cells where fluid can leak out. That's why there's edema here. So prostaglandin E2 mediates pain, hyperalgia, brings about heat, right? When there's blood flow, when blood flows close to the skin, it becomes warm. That's how it comes about. Vasodilation, essentially. Vasodilation, bronchoconstriction, synergistically acts with other pro-inflammatory mediators histamine. Now, thromboxane A2, it promotes platelet aggregation. Platelet aggregation means platelets comes together, right? So, mediate vasoconstriction, bronchoconstriction. Now, classification of NSAIDs. Now, NSAIDs can be classified based on certain parameters, and these parameters include chemical structure, which is the most important, right? Since we are discussing drugs, then selectivity of enzymes inhibited, and lastly, the plasma half life. So, now based on chemical structure, so we have salicylates, which include drugs under salicylates. That's based on the chemical structure, include aspirin, diflunisal, 5-aminosalicylate, sodium salicylate, magnesium salicylate, sulfasalazine, olazalazine, olasalzine. Now for acetic acid, we have indomethacin, we have diclofenac, we have sulindac, we have etodolac, we have ketorolac, and we have tometin. For propanolic acids, we have examples include ibuprofen, we have naproxen, we have phenoprofen, we have ketoprofen, we have forbiprofen, we have oxaprozin. Now for phenamic acids, we have meclofenamate and mefenamate. While for enolic acid, which is oxycam class, we have peroxycam, meloxicam, and tonoxicam. Now for ketone, lastly ketone, we have nabutamine, nabutan, nabumetone, which is converted to 6-naphthylacetic acid in the liver. A classification based on enzyme selectivity, which is also important. We have non-selective COX enzyme inhibitor, which include diclofenac. Non-selective, that means they inhibit both COX-1 and COX-2, right? So which include diclofenac, we have peroxicam, we have sodium salicylate, and we have naproxen. We also have tometin, ibuprofen, ampirone, phenoprofen, aspirin, tomoxipro, meclofenamate. We have sulindac, diflunisal, ketorolac, tenoxicam, florbiprofen, suprofen, ketoprofen, indomethacin. Now, COX-2 selective inhibitors include celecoxib, entericoxib, valicoxib, and meloxicam. Now, classification based on the plasma elimination half-life, right? So we have short half-life. That is, any of these drugs that have a half-life that is less than 6 hours is classified under short half-life. So aspirin is one example, diclofenac, ketofenac, ibuprofen, indomethacin. Now for long half-life, that is more than 10 hours, we have naproxen, sulindac, namebutone, piroxicam, and COX-2 selective inhibitors. Right, so COX-2 selective inhibitors fall under this long half-life. So COX-2 selective inhibitors generally have long half-life. That's what it's saying. So functions of NSAIDs generally. Now NSAIDs, like we said earlier in the video, has analgesic property, has antipyretic property, it has anti-inflammatory and anti-thrombotic, right? They inhibit thrombosis, they inhibit thrombosis formation, right? So NSAIDs toxicity include the GIT toxicity include gastric irritation, exacerbation of PUD, um, PUD, pelvic ulcer disease. Oh my god, sorry. Pelvic ulcer disease, right? Yeah. So, what am I saying? Pelvic. Jesus. Peptic ulcer disease. PID. That's just what has been coming to my mind. I'm so sorry. So, now mucosa erosion, then GI bleeding, of course, right? Now, exacerbation of PUD. Now, this is that's peptic ulcer disease. This is so important. You need to know this. Now, the reason is because if a patient comes to you with um, peptic ulcer disease, if you give that patient, if you give that patient now, you could understand this, and the reason for this is simple, is because that COX-1 that I said earlier, that brings about housekeeping function, which produces prostaglandin, that lines up, that protect the mucosal barrier. Now, if you give non-selective COX inhibitor, it will inhibit that enzyme, right? And once it inhibit that enzyme, that mucosal barrier will be lost. And if it is lost, that means gastric erosion will take place, right? So that's why it's important, right? You ask a patient, you do a drug history. Yeah, you ask, during your history, um, do you have any chronic condition, chronic condition such as ulcer? If the patient say yes, you understand. If they tell you they have ulcer, they have peptic ulcer disease, you should know that you are not supposed to give non-selective COX inhibitor. So important, so important, so important, so important. I would have put this thing in red, right? But anyway, you get you. So mucosal erosion, GI bleeding. Now treatment, discontinuation, right? Avoidance of NSAIDs in susceptible patients. The use of gastroprotective NSAIDs, such as COX-2, selective COX-2 inhibitor, right? Then take medication with meals. Use of COX-2 specific NSAIDs, right? Now, use of H2 receptor antagonist, proton pump inhibitor, misoprostol, proton pump inhibitors such as omeprazole, lansoprazole, esomeprazole, right? Good. So, prostaglandin 1 analog and sucralfate. So, now for CNS, headache, side effects in CNS include headache, confusion, tinnitus. Aspirin can cause tinnitus, dizziness, mood alteration, depression, aseptic meningitis. Now, hepatotoxicity can also occur, Reese syndrome, hepatitis, nephrotoxicity can also occur, which edema, hypertension, increased creatinine level, hyperkalemia, renal ischemia, nephrotic syndrome, renal failure. Now, hematological effects, it has antipyretic, um, uh, it has antipyretic effects, so it can cause bleeding, right? What am I saying? Antiplatelet, right? It inhibits platelet aggregation, so it can cause bleeding, blood dyscrasias, agranulocytosis, thrombocytopenia, aplastic anemia. So now cutaneous and hypersensitivity effects, urticaria, bronchospasm, anaphylaxis, Stevens-Johnson syndrome can occur, yes. Toxics, necrolysis, exfoliative dermatitis. Now aspirin is a salicylate. If you remember the classification under the chemical structure, aspirin is a non-selective COX inhibitor, and um, salicylates. So it is a weak organic acid. It's one of the oldest drugs used for the relief of fever and pain. Aspirin is used as a standard to compare the efficacy of other NSAIDs. Now the pharmacokinetics of aspirin is relatively insoluble, right? So its sodium and calcium salts have enhanced solubility. It's rapidly absorbed when administered orally. Absorption of aspirin from the rectal or suppository is slower and more reliable. The peak plasma concentration occurs 1 to 2 hours after oral administration. Now, it is highly bound to plasma protein. So that's to tell you that its free form within the blood is very, very little, right? So renal clearance is directly proportional to the pH of urine. In cases of toxicity, alkalization of urine is used to increase clearance. In cases of toxicity, alkalization of urine is an acidic drug. It can increase the acidic content of the blood. So it causes a decrease in pH level, right? So now to eliminate this drug in cases of toxicity, you need to do alkalization of the urine. So now for the pharmacodynamics is a non-selective COX inhibitor, like I said earlier. Irreversibly it irreversibly acetylates COX-1 and COX-2. To overcome this effect, new enzymes have been synthesized. It takes about 11 days in the case of platelets. It inhibits pain stimuli at the subcortical site. Now, clinical indications of aspirin: anti-inflammatory. If you want to elicit anti-inflammatory process, antipyretics, analgesics, antiplatelet, and non-inflammatory function. So, if there's an ongoing infection, you can give aspirin. That is after you have taken the history of the patient. You know whether you have found out whether the patient is a PUD patient, that's peptic ulcer disease. The patient has peptic ulcer disease. If the patient has, then aspirin is no go area, right? But if the patient doesn't have, then it's good. So anti-inflammatory, the patient has fever, is good for fever, to relieve fever, to reduce pain. Antiplatelet medication, so it can be given in cardiovascular conditions when there's hemodynamic disorder, right? It can be given when there's hypercoagulability, the blood is coagulating easily, right? So aspirin can be given. The non-inflammatory function. Now, anti-inflammatory conditions include rheumatoid arthritis, rheumatic fever, gout, osteoarthritis. Antipyretic rheumatic fever is an example. Analgesics, adjunct in cancer pain. Yes, an adjunct in cancer pain. Osteoarthritis, stomatitis. All these conditions they are very painful, so it's advisable to give aspirin. To antiplatelets, um, myocardial infarction prophylaxis, angina, CVA prophylaxis, cardiovascular accident prophylaxis, to prevent cardiovascular accidents. That's what you're just saying. So non-anti-inflammatory conditions such as colon and rectal cancer, Alzheimer's disease, radiation-induced diarrhea. Now, toxicities of NSAIDs: salicylism, that's salicylic poisoning, vomiting, um, decreased hearing, tinnitus, vertigo, metabolic acidosis. Like I told you, like I said earlier, that it can reduce the pH level, so it can increase the acidic content of the blood. It can cause respiratory alkalosis, cardiotoxicity, Ray's syndrome in children, salicylic poisoning. Thank you for listening. If you find this video educative, please subscribe, like it, and share. Thank you.